So that will assist in basically confirming the position, right, that the catheter has passed through the LES. So the intrathoracic pressure during deep breath will be a bit negative, so it's a bit dark, right? And you can see that the intra-abdominal pressure will be elevated during the deep inspiration. So after that, of course, we do the resting 30-second baseline as usual, followed by 10 5-meal swallows. All right. So this will be the standard protocol, and followed by a multiple rapid swallow. So for multiple rapid swallow, usually what we can do is, right, if the first test is normal, then you don't need to do it 3 times, right? But for those in which 3 times it is done for 3 times, you just take the best of 3, right, to look at the DCI ratio. So in the upright, after that, right, you turn the patient upright again, give another 60 seconds to adapt, right? Again, reconfirm your position in case the catheter has dislodged, right? So 3 deep breaths again, right? Followed by another 30-second baseline reading, and then just 5 more 5 meals of saline swallow, right? Followed by the rapid drink challenge, right? Before the test is finished. Of course, after that, you can add on other provocative tests, right? Such as a test meal or even postprandial monitoring. So this is the approach being introduced by Chicago 4, right? So basically step 1, the 10 wet swallows in a primary position, right? Primary position can be supine or upright, right? Depend on patient tolerability. So if there is any abnormality in the IRP, meaning if the IRP is raised, then step 2 is to actually proceed to wet swallows in the secondary position with multiple rapid swallow or rapid drink challenge, right? In fact, it is actually quite similar to what I actually introduced as a new protocol for usage in our motility unit previously. So MRS and RDC, right? That's step 2, right? And then depending on what are the findings noted, right? And step 2, if it's not done, then of course you can consider other challenging tests, right? Considering meal challenge and other things, right? And depends on the diagnosis as well. So the other thing that they have introduced in Chicago 4 is actually a new type of a new normal range, right? So unfortunately, MMS is not included in the metrics for IRP here, but for Medtronic and Diversitech, meaning the Sandhill system, they actually introduced a few normal range for IRP for both the supine and upright position, right? So previously, all our normal range are based on the supine position. For this one, actually, they have included the upright normal range as well, okay? So for Diversitech, the upper limit is 22. For Medtronic, the supine upper limit is 15, right? And in the upright position, usually the IRP will be slightly less compared to the supine position. So they have reduced the upright normal range to 12 for Medtronic, right? And 15 for Diversitech, which is the Sandhill system, right? And other than that, the other parameters remain the same, right? DCI normal range remains the same, right? The definition of weak and failed peristalsis remains the same, right? Premature or spastic contraction remains the same, right? Peristaltic break remains the same. Those things are not changed, right? And even the isobaric contour, right? The pressurization, 30 millimeter mercury, and also 20 milliliter mercury remains the same, all right? So these are some of the few provocative tests, right, that which we have done previously as well in USM, right, and is being incorporated into the new protocol currently, right? So multiple rapid swallows, rapid drink challenge, all right, solid test of meal swallows or solid test meals, and also postprandial meal observation, right? I won't go into detail because it's actually covered by another lecture previously. Right, so this is just an example of a postprandial observation, right, that you see, right, after you can pick up belching, you can pick up transient lower esophageal sphincter relaxation and reflux. You can also differentiate between reflux and rumination, right? So this is the new thing that is introduced in Chicago 4, right? Pharmacologic provocation. So they actually contain 2 different protocols. One is using amyl nitrate, which is actually a nitrite, right, which is a relaxant, right, muscle relaxant, given by inhalation, right, in a recumbent position. So what happens is basically after giving this, then they will look at the EGJ parameters again, right? So for example, in patients with EGJ outflow obstruction, after giving amyl nitrate, actually you'll see that there's a significant drop in EGJ pressurization, right? Suggesting muscular dysfunction, right? But if its cause is not due to smooth muscle abnormalities, then sometimes the reduction won't be significant, right? Usually less than 10. So the other parameter that is introduced is actually IV cholecystokinin, right? So what happens is that cholecystokinin actually, again, all right, it triggers two phases of response, which I'll show a bit later on, right? So basically, it induces a bit of a shortening, right, of the lower esophageal sphincter, and also some relaxation of the EGJ as well, right? And cholecystokinin in those with deglutitive inhibition dysfunction, right, such as and also patients with achalasia, actually they'll cause a paradoxical EGJ contraction, right? Normal response is EGJ relaxation, right? But in those with abnormalities, then they may get contraction paradoxically. So uh, so basically for disorders of EGJ outflow, right, meaning either achalasia or EGJ outflow obstruction, right, all require an abnormal median IRP in the primary position, right, either supine or upright, depending on the patient tolerability. And of course, EGJ outflow obstruction, right, requires an abnormal median IRP in both the primary and secondary positions, right, as well as other complementary testing, right. They have included inside the protocol. So for achalasia, I think the definition remains the same, right? There's nothing changed, right? 100% absent peristalsis, right? Failed or premature swallows, all right? Premature for type 3. And also should not have evidence of normal peristalsis, right? So this is the recommendation for achalasia. In particular, I like to highlight this area here in the red box, right? So basically, an inconclusive diagnosis of type 1 and type 2 achalasia, right, includes absent contractility with no appreciable peristalsis in the setting of IRP upper limit normal. So meaning when you see a patient with absent contractility, and if you look at the IRP, if it's a bit near the upper limit, right? Say for example, 15 with MMS systems or 20 with the Sandhill systems, right? So you have to suspect sometimes there could be a early achalasia, right? Especially in the setting where you see all these abnormalities, right? That's part of the recommendation, right? So basically for disorders of EGJ outflow, all right, again, right, the change is that basically the protocol included those with supine as well as upright positions, right? So that's the difference compared to the previous protocol 3.0. The other parameters and criteria remains roughly the same, right? So so this is how they actually come up with what is called conclusive, what is called inconclusive, all right? And what can be done to support the diagnosis, right? So basically for achalasia, I think conclusive means basically what is being defined according to Chicago 4, right? So abnormal IRP with 100% failed peristalsis, right? And basically that's for type 1, right? So for type 2, again, it's esophageal pressurization. And for type 3, you get premature or spastic, right? Meaning the distal latency is less than 4.5 seconds, right? So sometimes what happens is you get all these inconclusive findings, right? Which if you've done enough manometry, then you'll actually notice quite a number of patients ending up with these criteria, right? So where the IRP is not really that high, right? Upper limit normal, right? But you get all these failed peristalsis, right? Right? And sometimes you get right more than 20% swallows with band esophageal pressurization. So it could be an early type 2 achalasia or it could be an absent peristalsis, right? That kind of diagnosis. So, and the appreciable peristalsis, right, with changing position in the setting of type 1 or type 2 achalasia pattern in primary position. So what can you do when you get an inconclusive findings, right? So they have introduced what you can do, right, which is the supportive testing, right? So how to support your diagnosis of achalasia, you could do a time barium esophagogram, right? You can do it with a tablet there as well, right? So sometimes what you see is dilated esophagus, right? The barium retention, the tablet does not pass through, right? So the other thing that you can do to test for EGJ distensibility is the endoflip, right? which you can demonstrate reduced distensibility, right? So the distensibility index is lower than the usual limit, right? And also there's reduced maximal EGJ diameter, right? When you inflate the balloon. So the other thing to note about type 3 achalasia is that studies have been done, must be off opioids, right? So because opioids sometimes can actually increase the IRP, right? So for EGJ outflow obstruction, right, substantial position of the EGJ outflow obstruction in the supine position is unrelated to LES dysfunction, right? If we have done a lot of the manometry, we'll notice that a lot of these EGJ outflow obstructions are actually it happen in normal patient, right? So how to resolve this discrepancy, right? Where asymptomatic patient, you do a manometry, shows EGJ outflow obstruction. So they actually introduce other things to help you in the diagnosis, right? So because there's a lot of explanation why the patient shows EGJ outflow obstruction pattern in manometry, right? It could be artifact, it could be a hiatus hernia, it could be some mechanical obstruction or opioid effect, right? So they have introduced this thing called intrabolus pressurization, right? So what is intrabolus pressurization is, I'll show you later on an example, right? So basically it's like a stiletto type pattern, right? That you see in the shoe, right? That stiletto part is with the isobaric line of 20 millimeter mercury, right? So that is the intrabolus pressurization. So the presence of intrabolus pressurization actually suggests that is a significant LES obstruction, right? Compared to those without. So again, if you look at the criteria here, all right, so you'll see that, right, intrabolus pressure could be elevated, right? That could be, and on top of that as well, patients need to have symptom, right? So symptom meaning chest pain, right? And also dysphagia, right? Which need to be present as a part of the diagnostic criteria, right? So it's not just pure manometry, right? They have actually included symptomatology as well, right? For the patient to get a diagnosis of EGJ outflow obstruction, right? So because of that, right, so they've come up with a few recommendations for EGJ outflow obstruction, right? The few of them remains the same in terms of not meeting the criteria for achalasia, but do take note that some of these can be early achalasia, right? So I won't go into detail about the criteria, right? The guidelines are available for reading. So again, right, what they have stressed, the authors have stressed, right, is that for EGJ outflow obstruction during the initial approach, it should always be considered inconclusive, right, in the beginning, right, before your further workup and further investigation. And on top of that, you need the obstructive symptoms of dysphagia or non-cardiac chest pain to be present, right? Without symptoms, it's not considered EGJ outflow obstruction as well, right? And on top of that, there are some supportive evidence of obstructive physiology from a non-HRM test. So time barium esophagogram, either with barium swallow or with a barium tablet. Endoflip, of course, can help you as well. And of course, provocative testing that can help you would be like a rapid drink challenge, right? And basically it's showing that the IRP did not decrease significantly with a rapid drink challenge. A solid test swallow or pharmacologic provocation, right? To look for paradoxical EGJ contraction, right? Especially with cholecystokinin. So basically, conclusive, I think I won't go through again, right? So basically conclusive meaning it satisfies all the criteria mentioned previously, right? But for inconclusive EGJ outflow obstruction, right, what you have is just isolated abnormal findings, but which is inconclusive or manometric, right? This diagnosis of EGJ outflow obstruction. So this includes isolated IRP supine or IRP upright, right? Because now Chicago 4 requires both parameters to be raised. So for example, if your supine IRP is raised, but you sit the patient up and the IRP normalizes, then it's not EGJ outflow obstruction, right? It needs to be both raised, all right, according to the upper limit I mentioned earlier, right? So if you're using MMS, right, it will be 15 in supine and above 12 for the MMS system, right? For Sandhill, it will be 20 supine and 15 upright, right? It should be above this, right? but it's just isolated. So when you have a situation of isolated raised IRP and it's inconclusive, then the supportive testing will be things like time barium esophagogram, flip, all right? And of course, some of the provocative tests such as rapid drink challenge, solid test meal, right? And pharmacologic provocation, right? So these are the supportive tests that can help you to diagnose an EGJ outflow obstruction that is clinically significant. So this is what I mean by a time barium esophagogram, right? So as you can see, right, after 5 minutes, right, in achalasia, you can see a lot of barium retention, right, in the upper left corner, right? So this is what happens in after 5 minutes, right? The barium doesn't pass through the LES, right? And you can do the same thing with a tablet actually, if you look at diagram B, right? So 10 minutes after the swallow, the tablet did not pass through the lower esophageal sphincter, right? So this is a way to demonstrate, and there are some advantages of using a tablet compared to using barium swallow, right? So sometimes the swallow, there may be a slow leakage of barium, right? And it could end up being inconclusive because of that. But with a barium tablet, then if the tablet does not pass through, then it's quite more sensitive to pick up significant LES obstruction. Right, so this is a paper actually showing you that the cutoff that they are using for barium, right? So, for example, they will look at the barium column height, right? More than 5 centimeters at 1 minute after swallowing the barium swallow, and more than 2 cm at 5 minutes, right? Can actually differentiate significant EGJ obstruction, right? Either due to achalasia or EGJ outflow obstruction. So this is what I mean by endoflip, right? So this is another newer method of looking at the distensibility of the EGJ, right? By putting a catheter with a lot of sensors through it, right? And inside these sensors are all contained within a balloon, right? So the current will be passed through, right? All these sensors, and they'll look at the surface area of the balloon, right, as it passes through. And when the balloon distends the EGJ, they'll look at the distensibility, right, by looking at the pressure within the balloon as well as the surface area at the cross section, right? That's how they end up with a planimetry, which is something that you see over here, right? The distensibility of the lower esophageal sphincter. So roughly, I'll just mention about this, right? This is actually presented earlier, but it's just to show you the effect of changing the patient's position and also changing the consistency of the bolus given during manometry, right? So as you can see, the IRP in supine is actually slightly lower, right? 3.8. The IRP in the upright position is actually slightly higher, right? About 9.7 here. And you can see if DCI in using liquid is usually lower, right? 1,003 here. And the DCI, when you change it to solid, is usually higher, right? In this example, about 1,900. So for EGJ outflow obstruction, they have actually divided it into a few subtypes, right? Observed frequently when we are doing manometry. So EGJ outflow with spastic features, right? EGJ outflow with hypercontractile features, EGJ outflow with ineffective motility, and EGJ outflow obstruction just on its own, right? With no evidence of disordered peristalsis. So this is what I mean by, this is what I mean by with hypercontractile features, right? In the left, right, you can see a very high DCI above 8,000, right? And then in here, one thing to note is you can see this stiletto pattern, right? In the first two examples here, right? You can see a pressure here showing intrabolus pressurization, right? So this is what they are talking about, right? Intrabolus pressurization, right? Signifying a significant obstruction to cause the bolus to get pressurized due to the peristalsis, right? The second example is, of course, shown here is there's EGJ outflow obstruction, right? But again, there's no disorders of peristalsis, right? The DCI looks pretty normal, right? But on the only abnormality you see is this stiletto pattern, right? That you can see here. And the third example here is basically, right? Maybe an artifact, right? So because sometimes you see an isolated situation where there's nothing abnormal at all, right? So in which case, then it could be normal, right? So we can really use this, the third example, to label as a EGJ outflow obstruction based on Chicago 4, right? You need other supportive criteria, which is absent here. Right, so for disorders of peristalsis, right, coming to it now, right, basically the only difference here is that everything they require a criteria of symptom to be present, right? So if you pick up a patient without any symptoms, you couldn't really label them as having absent contractility or jackhammer esophagus or distal esophageal spasm, right? If they don't have any symptoms. And in patients with ineffective esophageal motility, right, usually the criteria is now from 50%, they have changed it to more than 70% ineffective, right, or fragmented peristalsis to be called ineffective esophageal motility, and you need to have symptoms, right? So for absent contractility, again, the authors mentioned that you need to investigate and exclude achalasia, right? So you can use provocative maneuvers such as a rapid drink challenge or solid test meal, or other adjunctive tests such as time barium esophagogram or endoflip to help with the diagnosis of absent contractility, right? Again, the criteria remains the same, right? 100% failed peristalsis, but it's just that you need to always consider achalasia in a differential diagnosis. Right, so this is how you get an example of absent contractility. Again, hardly any peristalsis noted, right? The IRP is not raised, right? And if you do a time barium esophagogram, you see a lot of retention and the barium column, right? And if you do an endoflip, you can see actually there's very, very high pressurization in the LES, right? Showing a very low distensibility index. So it's very stiff, right? The LES is not relaxing. So this is how you diagnose it, right? So disorders of esophageal peristalsis, right? So absent contractility, to be conclusive, of course, it satisfies all the criteria I mentioned earlier. Sometimes inconclusive if the IRP is the upper limit of normal, right? So if the IRP is upper limit of normal, better do a barium swallow or time barium esophagogram. Or if you have endoflip, you can do it to help you, right, as part of the supportive testing, right,